Okay, hello everybody, and thanks for coming along to today's webinar. Today we're going to be talking about the complex lives of children and young people who enter the justice system, and to do so we've invited along Dr. Hope Kent from the University of Nottingham, and she's also associated with the University of Exeter, and she's going to be talking about the multiple different diverse needs and complex lives experienced by children who are into the care and justice systems. Hope is a research fellow with the ADR UK. She's using large data sets to explore the life circumstances of those who enter the justice and the care systems. And we'll be talking us through some of our most recent research. Towards the end of the presentation, there's also going to be an opportunity for some questions and answers. Just before we proceed any further, I just want to flag up that we'll be discussing some content of a sensitive nature, which some people may find distressing. So please feel free to exercise some caution around about that. Step away if you need to do so. Also, really urge you not to record today's session using your device, your phone, or any other devices or systems or programs such as AI. Today's webinar will be recorded and hosted in the future on the CYCJ website or other platforms. And also to flag up the range of other webinars that will be coming up over the coming weeks, and we'll discuss that later on. Please do use the chat function to ask any questions as we go along, and we will get through as many of them as we possibly can at the end of today's presentation. That being said, delighted to hand over to Dr. Hope Kent, who's going to talk through some of our most recent research. Over to you.
Lovely, thanks so much, Ross. Can you see my slides all okay?
Yes, yeah, all good,
okay,
yeah.
Lovely. Okay, well, it's so great to be here. So thank you so much for inviting me, and I'm really excited to share some of these findings with you. As Ross said, I'm at the University of Nottingham at the moment, but a lot of this work happened whilst I was at the University of Exeter as well. I'm still affiliated with them. By way of background, my first degree is in clinical psychology, and since then I've been doing research around the criminal justice system, mainly using quantitative methods. So I like big data, admin data, secondary data, and I'm really interested to present these findings to this group today because I'm not a social worker by background. I don't have any experience in social care, so I'm confident that all of you will be able to kind of offer some ideas and really enrich the findings that we've got so far with those sort of perspectives. So yeah, as I said, this research kind of wasn't setting out to examine care experience, and that's just something that has fallen out of the results that we've found. So it's been really interesting. I'm going to cover 3 studies today. So the first study is about men in prison. The second study is about women in contact with the justice system. The third study is about children who are in pupil referral units, kind of excluded from school here in England. And then I'm going to go through some practical resources as well that might be helpful for anybody who is sort of working in a bit more of a frontline situation, particularly around acquired brain injury, which is a theme of this work today. These studies, I'm presenting them in this order because that's the kind of order that we did them in. So the men in prison study was part of my PhD, and then the women in the justice system study came out earlier this year, and then the children in PRUs, that's still a work in progress. So that's sort of, I'll try and tell the story of kind of how they fit together in the way that we did them. I do just want to start with a note on terminology though. For this presentation and for much of my academic work, I'm going to choose to talk about neurodisability. That's an umbrella term which includes conditions such as autism, ADHD, acquired brain injury, fetal alcohol spectrum conditions, and developmental language disorders, developmental communication disorders, developmental coordination disorders, all sort of conditions like that. And that sort of sits at odds with the neurodiversity paradigm, which is quite popular at the moment, but I've chosen that terminology for a really specific reason. I do just want to flag that because it can be a little bit jarring. And that, like, I am definitely a fan of the neurodiversity paradigm and the concept of neurodivergence. But I think for this academic work, in the particular field that we're talking about today, neurodisability is a slightly more powerful word in terms of the framing that I'm trying to achieve. So that's for a couple of reasons. First of all, because we have this United Nations Committee on the Rights of the Child. They wrote General Comment number 24 in 2019, which sort of explicitly states that children with developmental delays, neurodevelopmental disorders or disabilities should not be in child justice systems at all, even if they've reached the minimum age of criminal responsibility. And this sort of goes on to say that if they are in child justice systems, they should receive appropriate screening and support. So the disability language allows us to invoke those kind of legal protections a little bit more strongly in this context. I'm also using that disability language within the social model of disability, which is a model sort of proposed in the 1980s by Professor Michael Oliver. And what's really important is that we sort of separate this idea of disability from the idea of impairment. So somebody might have an impairment in attention and concentration, but that's not inherently disabling. What's disabling is how we respond to that impairment as a society. And the social model of disability sort of gives us this ability to critique our systems and structures in society, to see how we are disabling people who have impairments in particular areas. And so the social models, kind of rather than locating the problem of disability within a person and saying you're disabled because you have this impairment in a particular area, it locates the problem of disability within society and how it responds to that. Mike Oliver's work is really interesting, so I definitely recommend reading it because he puts it far better than I do. But essentially it separates out disability as a social state that's sort of imposed on people who get marginalised across society rather than any particular medical condition. So when I'm using that disability framing, it's not about sort of individualised deficit focus, it's about thinking about how our systems are disabling these children that we're talking about. So hopefully that's clear, and I did just want to spend a second on that because I know the disability framing can be a little bit jarring if you're used to neurodivergence framing. But essentially they're sort of achieving the same end, just in different perspectives. I'm also rooting quite a lot of this work within these sort of frameworks of cumulative disadvantage. So thinking about children's life courses and how disadvantage sort of adds up and accumulates and intersects across the whole child, rather than thinking about any one specific experience that child has had. And cumulative disadvantage as a framework, Dale Danoff has talked about a lot, and it essentially positions that your current social position informs your next social position. So if you are currently experiencing some kind of disadvantage, that makes it more likely that the next thing that happens to you will be disadvantageous as well. So these disadvantages kind of add up and accumulate. And we can see that in children's lives. So if they're experiencing early adversity, whether that's abuse, neglect, poverty, then that can impact the next thing that happens to them, whether that's struggling at school and getting excluded, or entry to care, or whatever happens next, then determines the next thing that happens, and these things sort of accumulate. Which doesn't have to be deterministic, because these things, the advantages can also accumulate. If you improve a child's social position, the next social position can get better as well. And what's really important about that is that small gaps early on in life, if a child is slightly more disadvantaged than another child, they don't tend to level off with time unless you specifically intervene. Those gaps sort of get wider and children face more and more disadvantage as time goes on. And that sort of ties into this stress proliferation theory, which we get a little bit more in the health world, about how stress begets stress. So if you have one stressor, you're likely to have the next stressor and the next stressor, and it's this kind of adding up and spiraling sort of disadvantage that children face. And you can see that playing out across their life courses. So that's sort of a bit of the theoretical framework that we're kind of rooting this work in. So the first study really came about through a collaboration with Park Prison in Wales. And Park Prison were an early adopter of this screening tool called the Do It Profiler, which is now rolled out across all prisons in England. I don't know what the situation is in Scotland. I think it's in a lot of prisons in Scotland as well. But in England, it's used on entry to education in prison. And this study we kind of developed in collaboration with Park and with Do It Profiler to use some of that screening data from men who were in prison. So we had just under 3,000 convicted adult men. We excluded the men who were on remand, who were just interested in convictions. And they were screened within the first 6 weeks in prison using this tool. And out of those men, 630-ish reported that they were care experienced, so about 22%. And the way the Do It Profiler works is it's kind of this computerized tool, and people log in, and there's like questions. There's an About Me model, which is all about their lives, and then there's questions on functional impairments that they might be experiencing. So do have any difficulties with attention and concentration, social communication, those sort of domains. And there's also like some functional skills screeners, so questions like, can you read this bus timetable, or which menu option is the vegetarian option? Like really simple questions about things they might need to navigate life on prison or in probation, telling the time, sort of functional skills like that. And when we sort of went into this, our question wasn't specifically about care experience. Essentially, Park came to us and said, well, we think there's a really high level of need within our prisoners. There's lots of neurodiversity, neurodivergence, and we're not sure how to target our resources, like which groups of prisoners are the most vulnerable. So we sort of approached this as quite an exploratory analysis, and we were looking at, okay, within the prison population where there is a lot of disadvantage, almost all prisoners have had almost all bad things happen to them, right? These are people who really are very disadvantaged in life. And we tried to work out like which groups of prisoners stand out as being particularly vulnerable to these poorer outcomes sort of in prison. So that first finding that 1 in 5 men in prison have been in care, that's not necessarily a surprise, because the care criminalisation is really well established as a pathway through things like police involvement in residential care settings, through exploitation, through general vulnerability, to justice system contact that's created by the ways in which systems sort of treat children in care, and that early life adversity as well, if they've experienced abuse, neglect, things like that. But the Do It profiler has this one question in it, which essentially asks, have you ever been fostered or adopted? And that's the question we're looking at here. So when I'm saying care experience, it's quite a narrow lens on care experience. It might not capture men who've been in residential care and things like that. That's a limitation of the study. Like I said, it wasn't designed to capture our care experience particularly, but this is just a variable that really stood out to us as being important. So as a comparison point, less than 1% of children are in care at any one time in the general population, but they're not directly comparable figures, because obviously our men in prison are reporting a lifetime history as opposed to like a point estimate at any one time. But the key thing that started to emerge was sort of this additional vulnerability for the care experience prisoners. So like I said, they're unusually uniform in having poor life outcomes. Huge proportions of prisoners have had experiences of homelessness and things compared to people in the general population. But what stood out was that care experienced men were significantly more likely to have these poor outcomes in a number of different areas. So they were more likely to have been excluded from education across their life course and referred to a pupil referral unit. They were more likely to be homeless or marginally housed. They were more likely to report substance use problems, and they were more likely to be unable to work either through illness or through disability. And these differences are all statistically significant, and the effect size, that Kramer's 5 effect size, is sort of small to modest, but for this kind of social science research in a very uniform group, quite a homogenous group, these are quite significant differences. So that sort of got us thinking about this enduring impact of care experience. So what is it about care experience for these men that has led to something that means that years later, when they're adults in prison, they're still experiencing this disadvantage? And we were sort of thinking about like homelessness, like, is this about actually being released from prison and not having those strong family networks to be able to fall back on? You know, there's sort of this experience of like being released from prison on a Friday afternoon with all your possessions in a bin bag. Where do you go? If you don't have any family support networks, family support backgrounds, it makes things much, much harder when you sort of get out of prison. And we were thinking about that marginalisation across the life course as well. Like, being excluded from education does exclude you from a lot of opportunity. It excludes you from like advantages in employment and things like that. So it has that impact across the life course again. And the other like interesting finding was that care experienced men were scoring much lower on all of our sort of neurodisability, functional impairment domains as well, which was quite interesting, because they were consistently scoring lower on attention and concentration, social and communication skills, coordination and motor skills, language, literacy, numeracy. Those 4 were self-report measures, so they're reporting that they're having difficulties in those areas. And then also they scored more poorly on the functional skills measure, which was not self-report. That's more of like a sort of cognitive assessment. So that's an interesting association, right? Like the men who had been care experienced seem to be more neurodivergent, seem to have more conditions that mean that that disability may have been imposed on them through their education system, their experiences of exclusion in that, and things. And so again, like we then went and did quite a lot of reading to sort of try and understand that association, because like the care criminalisation link is really well established. So how does disability kind of fit into that picture? There is some research outside of the UK which suggests that this isn't a unique finding. So in Australia, they did a study of crossover children, so children who are in contact with both child welfare courts and child justice courts, and they found that there were sort of half of those children had a recorded diagnosed condition that would come under the umbrella of neurodisability, and that obviously is likely to miss people because those children may not have had diagnoses and may not have had their behaviour recognised in school as being like an indicator of need. And they also found that those children who were crossover, who had those sort of intersecting disadvantages, were more likely to have had sort of earlier offending trajectories, so they would have come into the contact with the justice system at a younger age. There's also this question that I haven't really found a way to explore yet, but which I would like to look at in the future, is this intersection of brain injury and physical abuse. So I'll talk a little bit more about acquired brain injury and what it is in a second. But if children have been exposed to physical abuse and neglect sort of in childhood, it might be that they actually have acquired disability, so through things like brain injury, that come about as a result of those conditions. So sort of could work in that direction. There's also studies looking at abuse for children with disabilities. So children with disabilities are more likely to be victimised and to experience violence. So that 98 studies by Fang, that's a big meta-analysis looking at violence against children with disabilities, and they had roughly double the odds faced by children without disabilities. So that is sort of a really clear pattern that does exist. They maybe are more likely to experience adversity in childhood. And this US study as well, Vanderminden, I don't know how you pronounce it, but they looked at sort of just over 12,000 children, and we're looking at poly-victimisation, and the sort of indications from that study are that children with disabilities that fall into more like learning disability or developmental conditions like autism, ADHD, they're more likely to be poly-victimised, so victimised across lots of different sort of types of victimisation and have multiple types of victimisation than children with just physical disability. But even the children with physical disability were experiencing more abuse than other children. So this sort of link is there. I'm not sure we've pulled all the threads together yet to think about that as a complete picture. So I said I was going to come back to acquired brain injury, which I will just give you a quick whistle-stop tour of like what that is, because it's quite fundamental to the next study. So acquired brain injury is essentially, it's a leading cause of death and disability globally, but I think it's quite a hidden condition. Like not many people have heard of acquired brain injury. It's definitely a silent epidemic in criminal justice settings, so we know people with acquired brain injury are overrepresented throughout the justice system. You can get traumatic brain injury, which is through things like fights, falls, anything where there's a blow to the head. A concussion is a traumatic brain injury from sporting incidents, road traffic accidents, things like that. And then you can have non-traumatic brain injury, which comes from things like infections like meningitis, encephalitis, stroke, brain tumour, things like that can all cause an acquired brain injury. So when someone has a stroke, the ongoing implications of that, where they need to go through extensive neurorehabilitation, are because of the acquired brain injury that's been caused by that stroke. You can also get anoxic or hypoxic injuries, which happen when the brain is deprived of oxygen for a period of time, and that causes brain cells to die and kind of creates injury in the brain. It's a real spectrum condition, so historically it was sort of classified as mild, moderate, severe, but the field's trying to move away from that classification system because it's not very accurate, and it's really difficult to tell who's going to have what sort of impacts from a brain injury. So you could have something that looks quite mild, like a concussion, but actually there's impacts for sort of 3, 6, 12 months afterwards, and it becomes quite ongoing and debilitating. There are also instances where somebody's had what looks like a really catastrophic and severe brain injury, but actually makes a very good recovery. So it's very difficult to predict what the trajectory is going to look like. But we do know that repetitive injuries are cumulative in their effect. So you have lots of brain injury, it leads to lots more disability. And then also it can be a hidden condition as well. So it might be that somebody has an acquired brain injury but doesn't have any physical implications of that. So may purely be cognitive difficulties that they're experiencing. This is a little bit of a map. Like the brain is sort of split into lobes, and the location of the injury can have an impact on what sort of outcome somebody might have. This is just like super rough, but it does give you a bit of an idea of what that might look like. So particularly injury to the frontal lobe, which is often the most common, because you tend to hit the front of your head and then it may rebound backwards and you get these sort of contra-Q injuries at the back of the head. But generally it's the frontal lobe that gets injured, and then other implications in the rest of the other lobes. But that can lead to behavioural, emotional changes, things like lack of inhibition, so acting really impulsively, difficulty regulating emotions, difficulty with social and communication skills, difficulty with planning, organisation, executive function. All of those sort of things come from frontal lobe injuries. There's also like other difficulties that can arise in terms of like difficulties with coordination, like that sort of proprioception of understanding where your own body parts are and being coordinated with motor skills and things. There's memory problems that can come with brain injury, changes in sexual behaviour, increased aggression, difficulty with recognising like faces, understanding language. All of those sort of things can be results of brain injury. So it's really complex and it can be really wide ranging. It can also go along with sort of headaches, nausea, difficulties with balance, those kind of physical implications of brain injury as well. If you think about people coming into contact with the justice system, if you have a really hard time with speech, language and communication, you can't understand what people are saying to you. You also have difficulties with inhibition, difficulties managing your emotions and things. You can start to see how people would get themselves into situations that might lead to contact with the justice system if police and other sort of justice professionals don't have an understanding of brain injury. You can see how in court somebody might struggle to communicate guilt properly, or like perform these social performances that we expect of people in court, might struggle to follow instructions, participate in their trial in a sort of meaningful way. There's all kinds of difficulties that sort of emanate out from brain injury that lead to justice system contact. So that kind of brings me on to the second study. In that first study of men in prison, we didn't really have a good measure of brain injury. We just had those functional sort of areas. And actually, I think in the context of the justice system, those functional areas are really useful. It doesn't matter quite so much what diagnosis someone has, as long as we understand how to support them and understand that actually this person might have difficulties with memory or attention and concentration, and that's the sort of support that they need. So this study on women in the justice system was a reanalysis of some data that BrainKind collected. So BrainKind, a really fantastic charity, they work in the justice system supporting women and men with brain injury through their link worker service. And they collected some data with a specific interest in looking at brain injury in the justice system. So again, this wasn't a study of care experience, this was a study kind of looking at brain injury. And we had a look at their data together to sort of do a bit of a reanalysis and see what the patterns were a little bit deeper in the data. So this is a much smaller study. It was 66 women in contact with the justice system. And these women were interviewed rather than using a screening tool. So we got a bit more rich data on kind of what had happened to them across their life courses. Most of them were in prison, but also some on probation, some in community settings. And 29% of those women reported that they were care experienced. And obviously that was a better measure of care experience because it was richer from what they told BrainKind rather than just the answers to that fostered or adopted screening question. So the whole sample of women in the justice system was quite striking in itself. 90% of them had experienced domestic abuse across their life courses. 79% had experienced non-fatal strangulation, and that is linked to brain injury because it can cause anoxic or hypoxic injuries, those injuries where the brain is deprived of oxygen. That's often caused by non-fatal strangulation. And whenever I've seen BrainKind present these findings, or whenever I've presented these findings, some of the questions we get are often around unsafe sex and whether non-fatal strangulation is a feature of unsafe sex, and actually that's the direction of advocacy that should be taken. And that is important, and it's good that there's been more awareness of that recently and the dangers of that. But actually, the instances of non-fatal strangulation for these women were in situations of like attempted murder. Like these were extreme cases of violence where women had been strangled until they were sort of unconscious, and they were really significant instances. And there's literature sort of linking that kind of non-fatal strangulation to extreme coercive control in relationships and things. So it's a really serious indicator of domestic violence, rather than necessarily an indicator of unsafe sexual practices. So I just like to make that distinction. 80% also screened positive for a history of brain injury on BrainKind's screening tool, and 68% of the mothers in the sample, so women in the sample who were mothers, many of them had had children taken into care themselves. So you sort of see that intergenerational impact. And I think in the justice system, when we think about women in the justice system, they often play different sort of family roles to men in the justice system, and that impact on children is really significant. So this again is a comparison of differences between care experienced and non-care experienced women, and you'll see that those first 4 columns are statistically significant differences. So perhaps the most striking finding was that 100% of our care experienced women had attempted suicide in their lives, compared to about half of the women who weren't care experienced. And that is hugely significant. Like the mental health implications of that are massive, and that wasn't sort of a marginal or borderline finding. Like, again, women in the justice system have very poor mental health. So to find this group that have even poorer mental health, it is really massive. And we have this sort of mental health crisis in women's prisons at the moment. Like rates of self-harm are astronomical, and sort of safety in custody is really a challenge. So thinking about that life course history in terms of who needs the very limited mental health resources that we have in prisons, care experienced women seem to be a particularly vulnerable group. They were also more likely, that neurodisability column is essentially any report of diagnosed neurodevelopmental conditions, so things like learning disabilities or autism, ADHD, that sort of thing, under that umbrella term. They were more likely to have any of those diagnoses. They were more likely to be experiencing homelessness, again, similar to the men. And they were also more likely to have a diagnosis of ABI. So I already said on the brief screening tool, almost everybody reported a history indicative of brain injury, but these women reported a diagnosis of brain injury, which normally means they've been to hospital. And from the interview data, those care experienced women with diagnosed ABI were reporting massive injuries, like they'd been in comas, they had had really, really significant injuries, often as a result of domestic abuse. So that diagnosed ABI can be considered as a really significant, really serious ABI. And again, like those things were related to their life course history. So often for these women, abuse had started in childhood, they'd been in really unsettled family environments, and they'd navigated the care system, and then that abuse had continued into adulthood, so they found themselves in abusive adult relationships, which sort of compounded everything across the life course. There was some differences from the men's sample. The main difference was substance use. So the men, if they'd been care experienced, they were reporting more substance use. For the women, there was no difference. And that, again, could just be because of the amount of vulnerability across the whole sample. So for men, physical abuse and violence predict later substance use quite strongly. So it might be that the reasons for men going into care were related to physical abuse and violence. But for women, sexual assault predicts substance use very strongly. So given that almost all of them reported kind of domestic abuse in those situations, it might be that actually there was just a sort of effect where pretty much all the women had experienced that, so there was no differences. But it doesn't mean that it's not a problem for women in prison. Brain injury, obviously, like I just said, non-fatal strangulation was a key cause for women in prison. We couldn't look at brain injury in the men in prison, but that's definitely something to think about. And then that suicide rate for the care experienced women, the attempted suicide rate, the self-harm in England and Wales for women's prisons is like 5,900 incidents per 1,000 prisoners, and that's going up at the moment. So this is critical. Like, the care experience could be a key indicator for us to target in order to improve mental health in women's prisons. I don't have the statistics for Scotland, so I'm not sure what the statistics are for women in prison in Scotland, but I'm sure people on this call probably know. So again, like kind of taking that life course approach then and thinking about where this disadvantage accumulates across the life course. This is a sort of work in progress study that we have. We've submitted it for review, but it hasn't been peer reviewed yet. So if you see a published version and the numbers look slightly different, that's why. But we were thinking about school exclusion in England and Wales, and I know in Scotland you're sort of not really got permanent exclusions happening in Scotland, and some sort of fixed term exclusions, but have been sort of much further ahead in sort of policy responses to exclusion than in England and Wales, where exclusion is very, very common and also is sort of on the rise according to the most recent statistics, which is concerning. So pupil referral units, if children are permanently excluded in England and Wales or have lots of fixed term exclusions, they often go to a pupil referral unit. They're sort of melting pots of children who can't be in mainstream school for a variety of reasons, whether that's mental health, sort of behaviour, in inverted commas, or whether that's sort of physical disability. It's sort of a real mixture of children, and they tend to really have their education opportunities quite curtailed. So they maybe don't have access to a full curriculum. It's unexpected for them to get really good GCSE results and things. Like, they do have limited opportunity once they've been to a PRU, and mainstream schools are often reluctant to take those children back as well. So it's a population I'm particularly interested in. And essentially, the children came from 9 different pupil referral units. We screened about 730 children, which we think is the biggest quantitative look at children in pupil referral units. And the mean age of children was about 14, but they were sort of generally secondary school age. And we found that almost 9% of those children were care experienced. So you sort of see this funneling effect from like the general population, where it's sort of less than 1% at any one time, to school exclusion and that sort of start of marginalisation in pupil referral units where we have 9%. And then when you get to adult prisons, sort of much more overrepresentation, so between 20 and 30% of prisoners have been care experienced. You can sort of see this funneling away from the mainstream and away from education opportunities, away from employment opportunities, and sort of chances to find that sort of sense of identity and success in life. You sort of see that. Again, this wasn't a study of care experience, but we sort of looked at care experience. So these are our children in the PRU generally. These are some statistics comparing them to general population estimates of these conditions. So for all our children in the PRUs, they had an overrepresentation of neurodevelopmental conditions, more head injury than the general population. That 20% estimate in the general population as well is from the most generous study I could possibly find, which sort of includes any history of sort of sport concussions or really mild, have you ever had a knock on the head sort of questions, just to try and show that even if we take the most generous estimate in the general population, like the difference in these children in PRUs and people in prison is really significant. So yeah, big overrepresentation of neurodevelopmental conditions, which we would expect in a pupil referral unit. Also really poor mental health, so 41% had thought about harming themselves, nearly half had used drugs or alcohol to change the way they feel. Lots of instability, so lots of them have moved school 4 or more times. Lots of diagnoses of mental health conditions, just a really high level of need across the PRU population. Lots of co-occurring needs, so children, nearly half of children with dyslexia also had a head injury, also had ADHD. Children with, so 30% of children with a head injury also had ADHD. 22% of children with ADHD also had autism. So there's lots of co-occurring need, and there's sort of some research calling this a bit of a double jeopardy. So if you have these multiple conditions, they again sort of co-occur and amplify each other, and often professionals may have one in view, so that professional may be an expert in autism and know lots about autism and be able to support the child with that, but not necessarily have in view the other conditions that are impacting that child as well. And then obviously the big risk is that for these children in PRUs, they've been seen through that lens of the behaviour, like what behaviour is manifesting rather than what's actually underneath the surface of that. So even here we found differences with care experienced children. And again, like this was almost the only group that stood out as having significant differences. So care experienced children had a greater history of head injury. They were more likely to have used substance use to alter their mood, and they were more likely to report housing instability, so living in temporary accommodation or living in B&Bs, which again is quite significant because those children are known to systems. So we don't really have very good temporal order because this is cross-sectional data, but the fact that they're known to systems and they're still sort of reporting that housing instability is quite worrying, because they should be sort of really well looked after once they're kind of known to systems. That's an opportunity to intervene. Children who were care experienced also were more likely to skip those questions. So it might be that actually this is an underestimate of the difference, because I think if they're skipping questions, it probably means that those questions are sort of sensitive to them, so they maybe are under-reporting rather than over-reporting. So you've got these, sort of drawing this together then, you've got these threads that run through these life courses of these children, and head injury seems to be a key one, that acquired brain injury. We found that in the children in pupil referral units, there was overrepresentation of head injury, but particularly in the care experienced group. For men in prison, they were more likely to have functional need, which could be a result of head injury. We don't know, we didn't measure the head injury, but sort of neurodisability as a whole is sort of a concept there. And women in the justice system, obviously massively screening positive for brain injury and head injury, but likely to be really poorly understood as perhaps a driver of the behaviour that's causing frustration for other criminal justice professionals. So sort of thinking about screening for brain injury, I'm doing another project in some big admin data, which is finding that it's those with unidentified injuries who are at greater risk. So when we look in hospital data, if children have arrived at hospital, they've been in a car crash, they've got loads of orthopedic injuries, and they've got a code for like a skull fracture or something that indicates there probably is a brain injury there, but they've never been scanned or never been picked up by a brain injury team, and then they get released from hospital and go back to school. It's those children that are being excluded from school, not the ones who get the brain injury diagnostic codes in the hospital data. So it's that the under-identification of brain injury and not understanding what brain injury is or what needs kind of brain injury can create and what sort of behaviours might be associated with brain injury that's causing that vulnerability to school exclusion. So yeah, again, that study is kind of a work in progress, hopefully be published at some point, but it seems to be this under-identification that's key. So at the moment, I think head injury is kind of happening. If there isn't a hospital visit or a record of the head injury, then that's kind of showing up as behaviour in schools, so impulsivity, poor concentration, difficulty reading the room and responding appropriately to people. That's then getting sanctioned, so school exclusion, particularly in England and Wales, leading to alternative provision, which is then kind of part of this nexus then that creates vulnerability to justice system contact, and care experienced children just seem to be at the pinnacle of that. And again, like just to draw out that long shadow of care experience, like the impacts of it are still present in the justice system for adults. So adult men and women in the justice system are experiencing differential outcomes based on their history of care experience. And obviously I can't say anything about causality from this cross-sectional data, it is just associations, but the fact that they are having those poorer outcomes suggests that actually the support that they need is not in place across their lives once they age out of care. So in sort of a rights respecting system, we need better screening to understand the difficulties that children are having, treating neurodisability as an access issue. So it's about barriers to accessing support and interventions in the same way that other children would have access, barriers to accessing education, barriers to accessing employment. And sometimes you get this sort of effective intervention churn, which Nathan Hughes has talked about a few times, where, like, for example, if we think about probation for adults, if somebody is on probation and they can't keep to their probation conditions because they can't remember them, they can't organise themselves, they can't get to their appointments, they can't attend whatever they need to attend, they can't get to their mental health treatment requirements or whatever, then that's sort of seen as evidence of risk, like this person's not ready to be in the community, but actually it could just be evidence of inaccessibility, like that person just hasn't got the resources that they need to be able to meet those conditions, even if they have the very best intentions. So then you get this churn where not being able to access stuff means that you get seen as more risky and sort of churned back into the system. And the United Nations Convention on the Rights of the Child and the UN CRPD, the Convention on the Rights of Persons with Disabilities, are quite clear here. Approaches to inclusion, not exclusion, both in society, in education, in employment. By the time children reach pupil referral units, harm's already been done. There is evidence on the harm of school exclusion. And like I say, England are definitely woefully behind on that sort of evidence. And then the long-term support. So there's lots of policy looking at preventing the criminalisation of children in care, which is really important. But there are adults who are in the system who still have needs and require a bit more support than adults who are not care experienced. But I feel like once they age out of the system at 16 or 18, or in some cases up to sort of young adulthood, that support kind of stops and no one's kind of looking after these adults who have care experience as well. This is just a quick note on the United Nations Convention on the Rights of Persons with Disability, basically stating that you need to provide procedural age-appropriate accommodations in all legal proceedings, including investigative, other preliminary stages, and as well as witnesses to allow people to participate. And then it also talks about access to justice, so appropriate training for those working in the administration of justice, including police and prison staff, is really important. So I thought I would finish by just flashing up a couple of resources that might be useful. This is the Brain Injury Screening Index, which BrainKind developed. It's a short sort of 10-item quick brain injury screener, which can help to open up conversations about, does this person have a history that might indicate brain injury? It's not diagnostic, which is important. It is just a screening tool, but it's completely free to use if anybody would find that useful in their practice. They've also got a tool called ADAPT, which is developed to support professionals to have conversations about domestic abuse and sort of think about how brain injury might fit in with domestic abuse. And it's sort of a guided structure to facilitate those sort of conversations as well, because that can be really intimidating to ask questions about that, but it might be really important because we might be missing a key piece of the puzzle there. Headway have also got guides. So there's a guide for probation staff, there's a guide for I think there's a guide for prison staff as well. But the sort of key things in the guides are really transferable across. So they're all about tips and tricks for working with people with brain injury. Headway have also got support groups across Scotland, and they have a helpline that people can ring if they think they've had a brain injury. They've got a justice programme which supports people with brain injury navigating the justice system. And the other thing they have is a brain injury identity card, which is supposed to be recognised by the police. So it might say like, my name's Joe, I have a brain injury, and that might mean that I can't remember what you've just told me, or whatever that difficulty might be. It might mean that I shout when I'm upset, or like it just explains the behaviour a bit and can help people interacting with that person to understand a bit more about what their brain injury means. And then the final thing is the ABI Justice Network, which is part of UCABIF. So I'm the coordinator for the network, so if you email that email address, it comes through to me. But if you have a particular case that you're worried about or want to just hear more about brain injury in the justice system, we have online quarterly meetings where there's sort of generally hear some updates and research of what's going on kind of in this field. We've also got a domestic abuse special interest group as well for that intersection of domestic abuse and brain injury in the justice system. So yeah, that's me. I'm quite happy to be contacted by email or answer any questions that have sort of come into the chat.
Thank you very much, Hope, for a really thorough presentation, which is quite frightening in parts. But really, I'm sure I'm speaking for all the other attendees, is certainly raised their awareness of some issues that we're probably aware of, but didn't know as much about the issue as you've been able to articulate today. And then some of the data that you're presenting has real parallels to some of the research that we've been doing here at CYCJ, the Secure Care Census, for example, and our practice guide chapter will highlight some of that, and my colleagues have placed that in the link. Also really taken by the way that you framed some of the responses that we should have to children and people in the justice system through the lens of rights respecting, and certainly the approach that we would be promoting and advocating for here at CYCJ, and ties really nicely with our postgraduate certificate for children and young people in conflict of law, which one of my colleagues is going to drop the link to in the chat for any practitioners out there who wants to take the next steps in terms of their professional development. I've got some questions for you myself, Hope, but we've also got some questions in the chat. So the first one from Megan, I was wondering if you could, given from the research that you've provided today, or maybe even from the literature, can you give an account for what is it that has occurred that's resulted in those brain injuries? Are they accidental, non-accidental, or from women, within women, is it caused through domestic violence, for example?
Yeah, so for women in the justice system, it's almost overwhelmingly caused by domestic abuse. Like that is the key cause, so either through that non-fatal strangulation, like I said, or through hits to the head and things like that. And BrainKind did a study in 2019 in HMP Drake Hall where they were actually just looking at brain injury, but domestic abuse came through as such a strong driver of that. And then Tom Macmillan has a paper in The Lancet in 2021, which might actually be Scottish women's prisons, where he looks at significant head injury, and almost all of that was caused in the context of physical abuse. And we know that in domestic abuse, it's often targeted at the head and neck, and then this is sort of a really under-considered consequence of that. For children with brain injury, we've been, like I say, looking at the hospital records, and what we've been finding, like this is sort of speculation on the results that we've got, so it might be different, but what I've been finding is that there are children who have brain injury that's quite clearly a brain injury that gets identified, so things from brain tumour or stroke in childhood, things like that. It tends to be well responded to by the hospital and by the school. But traumatic brain injury, and like I say, particularly those under-identified traumatic brain injuries, seem to be causing contact with the justice system. So it tends to be where people haven't made the link between the brain injury and the behaviour. So sometimes meningitis as well. People don't realise that meningitis can lead to brain injury. So you speak to prisoners who will say, oh yeah, I had meningitis when I was 9, but they haven't ever made the association that might still be having an impact on those different functional domains. Or, like I say, it's traumatic brain injury through fights, through falls, through taking a car and crashing it, or like whatever that might be. So it's sort of bi-directional, like the behaviours that lead to justice system contact can also lead to traumatic brain injury in some instances. It's also really patterned by things like child poverty, and that might be through lower vaccination rates, or it might also be through like more limited supervision or lower quality childcare if parents are working multiple jobs and having to rely on like supervision where actually ratios aren't quite right and things like that. Brain injury can sort of come about from that. So yeah, it's a really multi-headed beast. Sure. But like anything, yeah, in those sort of areas.
And I suppose, particularly thinking back on my own practice as a time as a social worker, there'll be so many children who would engage in behaviour that could have resulted in this a brain injury being acquired, but the medical attention wasn't sought. Or so the figures that you're referring to there, the figures are going to be under representation really, because so many children and young people and adults don't get the medical attention required. Just going back to the chat, reflecting comments from June, who's talking about the overrepresentation of fetal alcohol syndrome disorder within the justice system. I know you alluded to that there. Is there anything more you want to say about that particular condition? And also, I believe that the Law Commission has excluded it from the SEND and Disability Review. Do you have any views on that?
Yeah, I think it's hugely under-identified, hugely, again, socially, demographically patterned into this group who are more vulnerable to being taken into care, the group that are more vulnerable to poor outcomes, and like it's just so important, yeah, to recognise it. I think that one of the strengths of the Do It profiler that I quite like when we're talking about children who are actually now in contact with the justice system is that it's transdiagnostic, so it captures those functional needs across different domains without needing people to recognise those specific diagnoses, because I think if you're trying to expect like members of staff in a secure children's home to recognise fetal alcohol spectrum disorder, that might be an uphill battle if they're also expected to recognise ADHD, autism, brain injury, learning disabilities. They can't be an expert in all of those conditions, but by screening transdiagnostically and understanding what the functional impact might be on that child, that's sometimes a way round for those diagnoses that are recognised less often. But yeah, I think it's a hugely overlooked area. I completely agree.
Thank you. Two questions about gender. The first one from Kay, she noted that within your discussion the women's data, you regarded with regards to substance abuse, you stated that the high ceiling for that population. Could you expand on that a little bit more for us?
Yeah, so essentially, just what I meant by that was that this is just sort of again theorizing from the literature, but for women who've had histories of sexual abuse and sexual violence, substance use is a really well-known way of sort of coping with that. And when you're looking at a population of women in prison, almost all of them have had that history of traumatic relationships and sexual abuse and sexual violence. So we didn't find any differences between the care experienced women and the non-care experienced women. And I think that's probably because they've all had these really traumatic histories. So there's not really a good control group who haven't had that traumatic history, if that makes sense. So I was just sort of, yeah, like offering that as it's not necessarily that substance use isn't more of an issue, it's just that all of these women have had that.
Yeah, it's really widespread amongst both care experienced and non-care experienced children.
Yeah, exactly.
Women. That's great, thanks. And on a similar note regarding gender, Anna is asking about the PRUs. 2/3 of the children were boys. Do you think that's an over-representation? And was there any differences between the boys and girls within the units?
That's a really good question. Boys and girls in pupil referral units do look a little bit different because girls are sometimes more likely to end up there for significant mental health difficulties, significant anxiety and things like that, whereas boys sort of tend to end up there through externalizing behavior and like being disruptive in the classroom, that sort of thing. And that's a massive overgeneralization. And I think it's definitely the case that neurodevelopmental conditions look different in girls and don't necessarily get recognised so easily. So girls with ADHD, for example, may not have so much of the hyperactivity. It may be more dissociative and look a bit quieter in the classroom. So those sort of differences in rates, with 65% being boys in PRUs, that's sort of generally representative of our exclusion statistics. Boys tend to be excluded a little bit more, but I have definitely not done a deep enough dive into the differences between the boys and girls in the PRUs that we were looking at. So future research for sure.
No worries, so we'll get back to this when you've done that. So I just want to pose another question. Just bear in mind the forthcoming webinars for CYCJ. Next week we've got one about restorative justice in Scotland and what that's going to look like. We've got a further session about the postgraduate certificate, and then later on next month we're also talking about alternatives to remand and how best to respond to children. So that's what into a risk of custody. So that's what we'll be talking about here in Scotland in terms of forthcoming webinars. And for a lot of those children who'll be subject to restorative justice or might enter in secure care, we'll be looking at how to deliver interventions. Given the high rates of acquired brain injury and neurodiversity that you're reporting on, in terms of practitioners, what should they be doing differently in order to make sure that the restorative justice support that are offered, for example, takes cognizance of the particular responsivity issues and so on? How best to respond to a child, for example, who's got an acquired brain injury?
Yeah, that's a really good question, and it's something that like I've sort of been playing with some ideas around for a while in terms of restorative justice, because I think there's a few things to just be mindful of. I think the first thing is, like I said, like the difficulties with sort of social performances. So, for example, if that's restorative conferencing or something where the victim is actually meeting with the child, like the child may not display guilt in a way that sort of looks like what the victim's expecting, and that sort of expectation or those sort of situations that a child could be put into need to be managed quite carefully to make sure that they match up to the actual sort of functional ability of the child to respond well in those kind of situations. I also think the sort of volunteerism has to be considered quite carefully as well, because if children, particularly fetal alcohol spectrum disorder, actually there's literature on those children sort of agreeing to things without understanding what they're agreeing to. So whether that's leading questions in interview or whether that's, would you be interested in doing this restorative intervention, this is what it involves. And children sort of nod along and say, yes, 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 I'm happy to do that. But actually, without understanding the depth of what it is that they're agreeing to and what the implications of that are for their next steps in the justice system, for their admissions of guilt and things like that as well, that are sort of intertwined there. So I think it's really, really complex. I'm not saying that it sort of can't be useful and can't be used, but I think there's lots of considerations that need to be made, and also just the general adaptations that you'd recommend across the board. So making sure things are done in quiet, low stress environments, making sure everything's easy read versions of rights and what's going to happen next, and really explained very well. Sort of preliminary visits to rooms where things might be happening, or just ways to get to know the environment so it's not so overwhelming on the day of the intervention and things like that. Yeah, lots of components to sort of consider, really.
That's great. Hope, thanks very much for the answer. And I think that responds to Hayley's question in the chat. She's asking about doing work with young women in custody and anything you would suggest to support that piece of work. I suppose we've got just enough time for one final question from Jen. It sounds like the reasons for people entering care, for example, acquired brain injury, domestic abuse, etc., are resulting in poorer outcomes rather than the experience of care itself. Is that right?
I don't know. I think there are things that happen in social care that can be harmful. So I've already mentioned sort of the over-policing of children in residential care homes. I don't know the situation in Scotland, so it might be that you're doing things differently, but I know in England, like often police might be called to a residential care home to respond to a dispute that probably doesn't need police to respond to, but staff are relying on police. But in a domestic home, it wouldn't be responded to by police. I think also like care instability, so moving through lots of different placements, things like that are really associated with difficult outcomes for children later in life. So I think there are elements of the social care system that can be harmful if not administered properly. One thing I will just say is that I have a colleague, Stan Gilmore, who always says that there's nothing inherent about care that is bad. So every single one of our prime ministers has been in care. It's just they were in the care of Eton or Harrow rather than the social care system. So it doesn't have to inherently lead to bad outcomes. But I think that just either through underfunding, lack of placements, like I say, not continuing care after 16, 18, going to placements in the community that are not safe or appropriate, living in Airbnb, in sort of B&Bs and things like that, that are just not conducive to good outcomes. Yeah.
That's great. Thanks very much for that answer, Hope. And just to flag up to people that my colleague Katya has placed a link in the chat to our e-learning module, which is free, which is all about rights protected within residential childcare, which people can go and have a look at. Thanks everybody for coming along. Reminder of next week's webinar regarding restorative justice, and all our forthcoming webinars be able to see on the link that was previously put in the chat. Thanks for coming along, and thanks again, Hope, for giving up your time today. Thanks everybody. I'll see you next time. Cheers.